Hi, everyone. Welcome to #CArthritis. It gives me great pleasure to be in our studio with Morag Crocker. Welcome so much.
Thanks, Cheryl. It's great to be here.
Yeah, it's just terrific to see you. I'm sorry it's virtual, but this seems to be the most efficient way of doing this. As you know, Morag, the whole sort of purpose, raison d'etre of the #CArthritis event during the meeting is to try to quickly translate knowledge that you're sharing in real time with your colleagues right out to the people who one could argue needs it just as much, and that's people living with arthritis. I'm going to just describe a little bit about your background and then we'll
Mhm.
get right into our conversation. So, for those of you in the audience who don't know Morag, she's an occupational therapist and occupational therapy practice coordinator at the Mary Pack Arthritis Program in British Columbia. As coordinator of that program, she really helps bring arthritis traveling occupational therapy service to rural remote communities like Bella Coola, Hazelton, Terrace, Haida Gwaii, and Williams Lake, and possibly towns in between, or folks who travel from towns in between. So, welcome to the studio, Morag. You've done such a great amount of work, I know, over the years, and it's really nice to be able to share what you're doing with the audience. So, first of all, why don't you tell our audience a little bit about yourself and your role at the Mary Pack? Talk about what is the traveling consultation service and occupational therapy at the Mary Pack Arthritis Program.
Yeah, absolutely. So I do. I'm based in Vancouver at our Mary Pack Centre here, but I do also, as practice coordinator, support our other sites. So we do have a site in Cranbrook, one in Penticton, serves interior health, and in Victoria for Vancouver Island. And we know though that there are few services in particular as you get into northern BC and up the coast. So that is what our TOTS, or our traveling occupational therapy service, tries to help support, is by sending an occupational therapist once or twice a year to those communities to provide that outreach service.
Yeah.
So to the communities that you mentioned. It's been really interesting though. We've actually just started doing these trips again last year since the pandemic. And we've been able to make some changes in how we offer service, actually by starting to connect more with people virtually.
Yeah.
So as much as we like to be in person rather than through a screen like this, it's actually been a huge benefit in terms of being able to start to get to know people and to establish that relationship before the clinician goes to the community to meet in person. So
Yeah,
so man, my role helps to coordinate all of that, the virtual
it's
health
like
piece and the travel.
juggling 40,000 balls all at once, I'm sure.
Yes,
You know,
absolutely.
Morag, we did not long after the pandemic was declared a pandemic. Arthritis Consumer Experts organization that I lead, and that is the host of this event, #CArthritis. We surveyed people about virtual care, access to it. And interestingly, which is interesting, but likely not surprising to you or to others who live in rural remote areas, access to virtual care isn't always assured. And people have technology barriers, just broadband issues that have been identified by government as something that needs to be addressed in order to further promote virtual care services and make them available. How have you worked around those kind of issues?
Oh, that's a good question, and
Yeah,
it's
I mean,
actually
maybe you haven't, and I'm
shifted.
sorry if I'm putting you on the spot.
No, no, I think we have, because actually prior to my current role, I worked with another arthritis program that I'll probably mention later, the Oasis program. And
Right.
I do recall probably 10 years ago, we had tried to do some virtual education and some small group sessions. And it was, even though the technology existed then, the really the infrastructure wasn't in place. And I remember one place in particular, a hospital that had the equipment, but the biggest barrier was that the space that the equipment was in was staff only. It was where all of the union
Oh,
information and so on. And so they didn't want to have patients or clients coming in there, and they didn't have any volunteers to facilitate them and so on. So here we were ready to offer this education, and we just really didn't have the uptake at the other end from the healthcare providers that would facilitate it.
Right.
So now I think people are much more aware of what can be done virtually. And so we've come, there's still a lot of barriers.
Yeah.
Sometimes our virtual connection is phone call. It's just to
Yeah.
start to establish that relationship.
Yeah.
But we had a really neat experience with one of our outreach communities up the coast last year, where we actually did manage to facilitate a virtual appointment where the community health nurse went and met with the client. I believe they had traveled by boat to one health
Wow.
unit because the other one was out of commission. The client didn't have the technology, so the nurse brought her smartphone, and then they drove together further down the road to where they could pick up cell service, and were able to facilitate a session with our OT here in Vancouver that way.
Bravo, bravo.
Yeah.
That's amazing. It really shows you where there's a will, and probably more accurately where there's heart and real
Mhm.
caring to provide that service. You managed to get her done, which is terrific.
Yeah.
Yeah, we also found out in our survey that people it's not a panacea. The virtual care option isn't for everyone, but most people said, yeah, there are some things that we can do to keep my care and to keep my own self-care going.
Yeah.
So it's not like people living with arthritis in rural remote areas weren't willing to use it. So I think that just urges, I hope, government on to make sure that broadband issues and equity issues are addressed in terms of access. Tell me a little bit about the workshop that you held, just completed at the CRA meeting. Super excited to hear about this. Kind of give us the high level cheat sheet from it.
Yeah. So our big question, kind of the title of our presentation, is what is complex osteoarthritis?
Right.
And the reason we looked into this is it's kind of the $1 million question for us. So as some people may be aware, Mary Pack's what we call it a tertiary arthritis service. So meaning that it's a larger program. We do serve people from across the province, and to provide that kind of advanced arthritis care or expertise to patients who have generally more severe or unusual medical conditions. So in this case, typically autoimmune arthritic conditions. So it's supposed to be kind of a third point of contact beyond primary care, beyond the secondary specialist, which in this case is usually the rheumatologist. So this idea of it being a tertiary center or tertiary program, it mostly relates to the medical care at Mary Pack.
Right.
We do have a number of specialty programs or specialty clinics addressing more rare conditions like myositis and scleroderma. We have a young
Yeah.
adult transition program. But we do have allied health, so OT, physiotherapy, social work support for these clinics, and for these complex clients. Now, the big challenge is that we also see people with complex osteoarthritis. That's what our referral form says.
Yeah.
And yet, that's never really been defined as, what makes somebody complex.
So
Um,
describe the complex osteoarthritis person, or the person living with
yes.
complex osteoarthritis.
Yeah, so we had lots of discussions about that, and some people would say, well, it's the degree of damage that you see on the X-ray, that's what makes them complex, or the number of joints that they have affected. And then, I think in particular from an allied health perspective, we look at the whole person.
Right.
We would consider somebody to potentially be complex if they have a lot of complex medical conditions and arthritis as well. So we have literally spent years within our program going back and forth about what this includes and who should be seen, knowing that unfortunately we do have finite resources, and the primary mission of our program is to address those more complex autoimmune conditions.
Right.
Um, so we actually took a quality improvement project starting, almost 3 years ago, where we looked at people coming into the program who had a diagnosis of osteoarthritis. And we actually captured data in the end on, I think it was 52 individuals who received treatment through our program. And then we looked at what were the common factors kind of at the end of their care based on, the clinician that was working with them, a very experienced arthritis clinician, and had determined that they were complex. And so what made them complex and at what point could we figure this out? And so that sort of gave us our two main takeaways, which we shared at the workshop just now. The first one being that what information we get with a referral to our program is really insufficient for us to decide at that stage if somebody is complex. And we suspected that. And it means that probably a fair percent of the time, if we're turning away a referral, maybe we're missing the mark and that person really does need our services. And similarly, we might be, involved in care with somebody who perhaps could take more of a self-management approach. So we know we need more information. And then the other thing that we looked at or determined was what factors are most significant in making somebody what we now refer to as a complex presentation, because it comes down to a number of things. So it does include the number of joints affected. If somebody has multiple joints affected, they tend to be a little bit more complex to treat and to self-manage. The big thing, though, was the presence of functional or activity limitations. So things like being unable to take care of yourself or to work, to fulfill other valued roles. So that kind of participation restriction. And then pain. We know that in arthritis, pain is a big factor in limiting function as well, too, and impacting people's lives. And sure enough, that showed up as the number 2 factor was with pain with activity and pain with rest. And then the other key things were, the age of the individual, their ability to cope with pain, to have those coping skills, and having a lower physical activity level. So lots of important pieces of information that we don't currently get with our referrals for people with osteoarthritis. And so what we do next is kind of the next step of the project. Will probably involve working with the clinicians here, with some patient partners, and the rheumatologists and doctors who refer to our program to figure out how do we get this information so that we can accurately
So that's
treat the right
super,
people.
super interesting, Morag.
Mhm.
So I'm guessing then the referrals that come to you are coming to you from family physicians
For the most part,
who
yes.
are time strapped.
Yeah.
Arthritis very rarely actually, or joint pain or joint complaints rarely gets discussed
Yeah.
during an examination.
Yeah.
It's just people, and part of that is because the public thinks nothing can be done about it.
Mhm.
They hear from their mother or father, from their grandmother or grandfather, or their elder in their community, that it's kind of one of those grin and bear it diseases, and it's not. And
Absolutely.
there are some real things that can be done, and you're one of the experts who deliver those real things that can make a difference in the relief of pain, the improvement of function and activity, et cetera, et cetera. We'll provide a link at the end of this. We're hoping some family doctors are watching. It's the number one reason that someone over the age of 60 visits their family doctor is because of joint pain, which is likely osteoarthritis. So that it's not baked into an annual physical, that it's not something, every time I see my family doc, they listen to my heart, they listen to my chest, they look in my ears, they look in my mouth, they look in my eyes. All they have to do is touch a few joints and ask a few questions about joint pain to tell you whether there's a real problem. Because as soon as you ask one question, Morag, my experience as a health educator and a peer support person in the community is, as soon as you ask one question, let me tell you, you're going to get a story. And I almost think they want to avoid that, not out of professional neglect, but simply time,
Mhm.
right? So the more prepared a person with joint pain can be in going in and talking to their family doctor or their physiotherapist or occupational therapist, if they're seeing someone not trained in arthritis, is to raise some of these classic red flags that you've just identified. So sorry for the little soapbox rant there, but it's, I've been doing what I do for a long, long time, and so have you, and we kind of know where some of the big gaps are. If only we could photocopy people who are trained as you are, we'd solve all the problems in the world, wouldn't we?
Well, and then the other one that we didn't touch on there is the shortage of family doctors.
Right,
So, you know,
yeah.
that's
Well,
another
which is
barrier.
directly connected to the time piece.
Yeah,
They're
absolutely.
they don't have the time because they have, 40 people to see that day.
Yeah.
Like it's a I tip my hat to every single one of them. My heart goes out to everyone because they're trying their darndest, but overwhelmed by need. Tell
Absolutely.
us, Morag, the theme of this year's meeting
Mhm.
is shared decision making. And
Mhm.
boy, oh boy, in chronic disease, you can just underline that 40 times to emphasize those words,
Mhm.
and how important they are to making progress if you're a person who's actually living with the disease. Because we know how valuable it is, it actually improves outcomes if you have a really good communication strategy or quality with your care providers. But tell us about how important it is between care providers. So not just you and me as a patient clinician, but you as a clinician to clinician,
Mhm.
or clinician to administrator, if you will. But shared decision making. Talk about how important that is
Mhm.
to arthritis health professions.
Yeah, I think I mean, as you say, it's kind of the core of what we should be doing
Yeah,
in healthcare in general, but especially in chronic disease management. And I think what we talk about with shared decision making is this perspective that each person is kind of an expert in their area. So, you know, the healthcare provider may be the expert in, you know, best practice in that area of treatment. And the client, of course, is the expert on their life and what's going to work for them. And then you mentioned some of the other healthcare providers. You know, it's very interesting. I just observed another session where it was interesting watching rheumatologists and another medical specialty, and interesting how little knowledge they had of some of the aspects of each other's care. And I think while, you know, allied health providers, we pride ourselves on working interdisciplinarily and understanding each other's scope, none of us really can fully understand what each other team member brings to the table, including, as you mentioned, administration, you know, leadership, and so on. And so I think with that shared decision making, it really does have to be kind of a meeting of the minds where everybody sits down to share what they can bring to the table, and in the context of an individual client, what they can offer that person, kind of in their journey of self-management. And then it's up to the client or the individual to identify what will work for them and what they want to take from that kind of offering.
yeah, it's sort of like being at summer camp and sitting around the campfire singing Kumbaya. We all want to
Yeah,
be kind of
yeah.
together in that circle, focused on the person who actually has the
Mhm,
lived
mhm,
experience and letting
mhm,
that lived experience drive the conversation
mhm,
around
mhm.
shared care,
Yeah.
which then comes back to me. And I now am better at self-caring because I
Yeah.
understand
Yeah.
what shared care is, as well as the people who are collegially trying to group together to take better care of me, if you
Mhm.
will.
Yeah, and
Um,
I think as well, if I can just add
yeah,
that there's
yeah.
consistent messaging then too, if everybody is on, if you
Ah,
really have that collaborative team approach, that is definitely something that I've heard in the arthritis world and in other areas too, is, you know, if people are trying to educate themselves and seek out information, if they're getting conflicting information from different healthcare providers, or maybe they're, you know, accessing less, you know, reputable or evidence-based information on the internet, that can really add a layer of complexity as they try and identify, you know, what is the best path forward.
yeah.
So everybody being on the same page and reinforcing the same messaging, I think is really helpful too.
And electronic medical records should help that.
Mhm,
But we have such a patchwork quilt,
mhm,
or big holes in the quilt, better said, probably, with electronic medical records. They should exist. No one can believe that they don't exist everywhere in this country. Some are using some type of software, others are using another. But really, the tool that can really help power shared decision making is still yet to be sort of solved, right? Listen, I don't want to take up much more of your time, Morag. I know how busy you are. I kind of feel if I'm chatting with you, you're not out there dealing with one of your patients and trying to help them. So on that note, as we close our conversation, when you think about occupational therapy today and even team-based kind of models of care for people with, let's be specific to complex osteoarthritis.
Mhm.
What do you think are kind of the top three things I drew the lucky straws. I have rheumatoid arthritis and I have complex osteoarthritis. Some of it was primary osteoarthritis and some of it's as a result of joint damage because of my rheumatoid arthritis. What would you say to someone, living and likely struggling with complex osteoarthritis, who have, multiple joints involved, who, have can't work at the job they love or work at it as well as they would like, or having even to take a demotion, not being able to do the things they want to do in their personal life, giving up, the things that made them happy as a human being. What are some of the things that you could sort of say are real sort of, I don't want to say game changers, but could really help someone?
Well, I'll start with the tricky one. I think, and
Yeah,
I say this, from a personal perspective and a professional perspective,
yeah,
that when it comes to any chronic disease or just maintaining health, we all wish that there was one single thing that we could do that would make the difference. And unfortunately, in chronic conditions in general, but I would say in particular with something like osteoarthritis, where we don't have the same medication options that we
right.
do, say, for rheumatoid arthritis, it's usually a combination of all these different kind of wellness factors. So it's things like addressing your sleep, your exercise or your activity levels, figuring out what you can do with the state of your joints and your current health, your diet, your stress management. All of those things combined are probably what's going to make the difference in
Yeah.
terms of having long-term success in managing the condition. So that's much easier said than done.
Yeah,
And
but
hopefully
it's
that's where we
important
can
people
support as well.
understand it's like a tangled web.
Absolutely.
And understanding where the tangles are is sometimes a really important piece of taking a step forward in your care.
Yeah,
Yeah,
absolutely. And so I think as part of that and untangling that is educating yourself.
yeah,
And so obviously we know that is a challenge in, finding the right sources and finding the right people, but we've got some great resources being shared today.
yeah,
So, when you know more, I think you can take care of yourself better. You can start to untangle that web and you can advocate for your needs more. You can be a little bit more specific and maybe get more from those brief healthcare interactions that you're having.
yeah.
Um,
Asking the right one or two questions can take you a long way forward in your care, for sure.
yeah,
And feeling confident enough to ask them. So,
yes,
and we'll give some tips at the end, some links to some of our programs. We'll certainly be sending folks to the Mary Pack Arthritis Centre and some of the public information sources you have available.
yeah, yeah, absolutely. And I
Yeah,
think that the last thing I would say is, maybe in those earlier stages or the darker times is to connect with other people in a
yeah,
similar situation. I think we can't underestimate the power of that peer support and talking to somebody who's actually living this at the same time, whether it's to find out, where they got their information from, or even just to understand that there are so many other people going through the same struggles.
yeah.
In particular, as you said, with osteoarthritis, the numbers over the age of 50 or 60 are pretty staggering. So for people to know that they are in good company and that there are resources out there, it just sometimes takes a little bit of time to find them.
Yeah, and also recognize out in the audience that osteoarthritis isn't an old person's disease.
Mm.
We know now it's a process that can start very young in life. So, I have friends and peers in my community who are 30 and have a hip replacement, 35 and have a hip replacement because they have, you know, a type of osteoarthritis that started and has been very aggressive. So
Mhm.
those are great tips. Thank you so much, Morag. We're going to provide them with those
Yeah.
links to credible resources. And just remember, folks out there in the audience, that you are what we call an N of one. Every single person living with a type of chronic and complex osteoarthritis is like a snowflake. So while we encourage connecting with people, just remember treatment plans, approaches to self-care are all very individual because we are snowflakes. And so it's not a one size fits all, but there are some basic principles that do help everyone. And those will be found in the resources that will follow in the seconds following our saying goodbye to Morag for now. We're so appreciative that you could spend a bit of time with us, Morag. Congratulations on your workshop. Sounds
Thank
like
you.
that was very successful and, of course, very important work. And to your audience, we will see you again. We have some more episodes of #CArthritis coming your way. Bye for now.